Welcome everyone. We are here for the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Thursday, October the 21st, 2021, post AQO. So thank you everyone for joining today. On the call with me today from the STS side, we have myself, Donna McDonald. We have our surgeon leaders, Jeff Jacobs, Dr. John Meyer. We have Leslie from our core group, and we also have Chastity from our CHSD consultant. So thank you guys. From our IQVIA team, we have we have Joe, Case, Melanie, Michelle, and Steve. So thank you everyone for joining me today. As always, please submit your questions via the Q&A. If you would like to raise your hand, the raise hand function is enabled. Please make sure your microphone is enabled if you need to clarify a question. But again, please submit your questions via the Q&A and not via the chat. So thank you, everyone. From our agenda for today, I'll provide a brief STS update. Then we'll turn things over to Chastity for complications revisited, risk-adjusted analysis, reporting clarifications. And Leslie will touch on some AQO, post-AQO summary follow-up. Then we'll turn things over to our IQVIA team. And then, as always, we'll finish up with our user feedback. And again, if you have a ticket number that you've submitted to the IQVIA team, if you could, and you have follow-up questions, if you could, please include that ticket number when you submit your question via the Q&A. So let's go ahead and get started. All right, for our STS updates, the 2020 harvest analysis, those risk-adjusted reports were released on Monday, October the 11th, just prior to the start of AQO. So again, those reports were released. If you have any issues accessing the IQVIA platform, please feel free to reach out to tech support. If you need password resets, surgeons need access and have issues with their login information, please reach out to us at stsdb@sts.org. For our 2021 harvest update, please continue using the open submission and cleaning your data as we previously discussed. We are looking at a harvest close date of mid-December. We don't have the official date set yet. A formal communication will be coming from the STS first thing next week, early next week. So again, we are looking to close the 2021 harvest in mid-December. And of course, the 2021 harvest will include procedures up through June 30th of 2021. We're working to get back on schedule for 2022. So our 2022 harvest close dates will be posted shortly, will be coming soon as well. And again, we need to get back on our regular rotation. The spring harvest typically ends in March, and our fall harvest typically ends around September. So again, just a preview of what's coming down the pike. Some more information, again, official notification will be coming from STS next week. 2021 AQO wrap-up. Thank you everyone for joining this year. It was our highest attended AQO ever. We appreciate you all so very much. Thank you for joining. We look forward to your feedback. Emily wanted me to share some last minute details with you. The live day sessions are now available on the virtual meeting platform, so you can access those. Attendees will have access to the virtual platform until October the 29th of 2021. All of the content will be moved to the STS Learning Center, and after October 29th deadline, all of the content will be moved to the STS Learning Center, and access will be available until AQO 2022. The CE and CEU certificates will be processed once a month based on the prior month's completions, and this rolling system will continue for 3 months and end on Saturday, January the 15th, 2022. So that is the deadline to get in for the CEU certificates is January 15th, 2022. Dr. Gulasarian's quality improvement surgeon experience video should be uploaded shortly. We apologize for the delay in getting that presentation uploaded, but Dr. Gulasarian is working with us to get that presentation uploaded and available within the platform ASAP. The IQVIA CHSD report on demand presentation was removed, and that presentation will be covered outside of AQO. With the release of the reports coming just that Monday prior to AQO, it was not feasible or not able to get that report on demand presentation completed and posted it in time for AQO. So again, we do apologize for that, and we can have more information on that CHSD report presentation to be shared at a later date. That's all that I have from the STS perspective. I'm going to turn things over now to Chastity and Leslie to tackle complications revisited, risk-adjusted analysis reports, and post-AQO summary updates. So Chastity, floor is yours.
All right, great. Thank you, Leah. So let's start with complications. And next slide, please. As you recall, we revisited our complication definition to make sure that we're not only collecting complications within 30 days after surgery, and but including also then the entire episode of care should a patient transfer to another facility. So in my attempt to make the language better in the training manual, I clearly made it more confusing and got really excited with my strikeouts and made you all more confused than you were coming into the last webinar. That will be fixed this week, and the training manual updates will go out in the next few days as well. So I apologize, but let's review then exactly what I said and meant to say in the training manual at the last webinar. So next slide, Leanne. So we want to collect complications through the patient's entire surgical hospitalization. So if a patient were to discharge home before the 30th postoperative day, we still want to collect the complications through the 30th postoperative day. If the patient were to transfer or discharge to another facility, you're going to collect the complications through the end of the episode of care. Next slide. Another way to say it, thank you, Leslie, who said it much more concise than my wordiness, was that you're going to collect complications for the time frame that is the longest. So whether this is through the 30th postoperative day or through the end of the episode of care, which will also be your database discharge date. So based on how where your patient discharges to, you will know and when you will know which will be the longest time frame for you. So again, we will make these updates to the training manual accordingly, and so it should decrease your confusion, and I severely apologize. Next slide. And with all rules, there are always exceptions. So we do have some complications that we would consider what we would call transient complications. And I've listed these 4 complications here. And these are data collection will end at the time of surgical hospital discharge. So if you've done the surgery from your facility, regardless of where the patient is discharging to, home, acute care, chronic care, these will end at the time that the patient leaves your hospital. And so this is arrhythmia necessitating pacemaker, temporary pacemaker, and then renal failure where dialysis is not present at hospital discharge. So whether it being temporary dialysis or temporary hemofiltration. And then lastly, neurological deficit, a transient neurodeficit not present at discharge. So I will work on the wording for these to make sure that it says that the data collection will end at the time of the surgical hospital discharge, and so that they will look different than the other complications that we're collecting through the aforementioned timeframes. So again, if you have more questions about this, please submit them to the FAQ box and we will get you all the clarification that you need. Next. Okay, the 3.41 stat score update. So this is not related to the 2020 stat score update. Leslie's going to speak on that in her portion of the slides today, but I'm referring to, there were 16 new procedures that were included at the time of the 3.41 version upgrade. However, these 16 procedures were rolled out and they did not yet have defined stat scores. And as you know, the stat scores were released in June of 2020. They were not included in your current analysis report, the ones that we're looking at right now that were just released in October of this year. So this was not handled as expected. And we also know that depending on which of the new procedures that you selected, they're not all being handled well, as expected, but they're not being handled even the same amongst one another. TETs might be being handled one way in the analysis and the DORV repairs might be handled another. But we're investigating how each one is being handled. But the good news is With the new data harvest that's being set to close in mid-December of this year, this will all be taken care of, and these will be analyzed as expected in the upcoming harvest. And these are the 16 procedure codes. I know for some of you, your data vendors may have included these codes. Well, you already had the procedure terms in your databases because that came out at the time of harvest. But I know some vendors went back and then also updated the stat scores. But here's the list for those of you who may not be aware of what these terms were. And so if you see a mismatch in your current data report, this is the reason, and it will be rectified in the next harvest. All right, moving on. So the risk-adjusted analysis reports, as I asked you to do at AQO, please submit all of your questions related to the analysis reports, points of confusion and things so that we could handle them here on this webinar. So many of you did that, and I very much appreciate it because it's what helped me populate these slides so we knew what to talk about. But I do want to say, if you have any problems where you see what you think are errors, or you've identified any incongruencies that you can't figure out, please submit a ticket to the IQVIA, or I guess the STS tech support. And Leanne always includes the tech support information at the end of all of these presentations. And so she'll review that at the end of this. But just so you know, please submit anything that you see in error there. The webinars are really going to be about the education and understanding of the tables, and I won't be able to fix your problems within your reports themselves. So if you think there's a problem, please submit a ticket. So a few notes here. The risk-adjusted dashboard reports, while named risk-adjusted dashboard reports, not all of the tables are necessarily risk-adjusted. So you really have to look at the title of the table and figure out what's going on within each table. And there are some noted differences between the tables. So the population may change. So whether it's all operations versus a select type of procedure, as in the benchmark or lesion-specific operations, the analysis being completed on each table is different. And so sometimes it's, purely just mortality, and other times it's stratified in different ways by age, by stat score and such. And then of course, then the comparison groups. Are you looking at the STS aggregate? Are you looking at, certain percentiles, mins and maxes, things like that? And so you have to really look at each table differently. And again, read your CHSD analysis overview. This will break down the types of analyses being done. And if you have questions, please submit them to the FAQ box, and so that we can include them in a webinar and get back to you on, what the differences are between certain tables. Okay, so I would say the number one question I have received over the last week is the mortality analysis that is in table 1 versus table 16. So I want to lay out the next few slides to discuss those. And again, I don't think that this is super easy at all. And you learn something new every time you put slides together, I promise you. So in table 1, you have unadjusted raw data. So nothing is being applied to your data in that overall mortality analysis. So it's really looking at that you have a specified population, which is your CPP, no CPP index operations. And here's your number of mortalities, divided by your eligible operations. This is stratified in table 1 by each year of the analysis, years 1, 2, 3, and 4, and then a total 4-year analytic window is included as well. And you see then it goes on to stratify the mortality by your stat score. So this is your first place where you could see a discrepancy in the included cases and the number of mortalities. So I can speak to my data that I have, and I'm just going to give an example. I have 20 mortalities over the 4-year period, and I have, 1,000 operations. But when I get down into when it gets stratified by the stat scores, I have 2 less mortalities and a few less eligible operations. So why is that? The only thing that's changed is we're now stratifying the mortality by the stat score. So that tells me I likely have some mortalities that occurred in patients or procedures that occurred on patients when speaking to the denominator that don't have, that procedures were not associated with a stat mortality score. So I can go into my data and validate that. I expected this because I knew my data going into the analysis, that I knew I had patient deaths that occurred with procedures that did not have associated stat mortality scores. So that is your first source of discrepancy within these tables. Now, when we look to table 16, it does use your raw data, and that's when we are calculating just your overall observed mortality rate. But then there's also your risk adjusted data. There's only a 4-year analytic window here. So it is not breaking it down year over year, but it's the whole 4-year window that's being included. Every procedure in this table must have an associated stat score, as well as there's specific model criteria that's applied. And within that model, you have to have certain completion of data points. And so that's where we start getting into differences between the stat mortality analysis in table 1 to the stat mortality in table 16. Okay, so I tried to put this in a kind of visual way for those of us that like to look at this visually. And so we're going to start overall with mortality analysis. Anywhere in this report where there is a mortality analysis, there's some basic information or basic requirements for a case to be included. So the first thing is you have to have data completeness for the fields that are required to determine mortality analysis. And I've put them over here in blue to the, I guess, my right of the box. And this would be, you have to have a valid date of admission, primary diagnosis, primary procedure, and then mortality status at different time points, hospital discharge, database discharge, and then 30 days post-operatively. If any one of these is missing, then your case is excluded from any mortality analysis, both in table 1 and in table 16. Then you have to have an eligible operation for the episode of care. So again, eligible operations for overall mortality will exclude certain procedures. This will be primary PDA ligations done in patients that are less than 2.5 kilos at the time of surgery, not birth. Pacemaker and ICD procedures in patients that are less than 30 days. Pectus repairs, bronchoscopies, and organ procurement. So all of those right off the top get removed and will not be included in any mortality analysis in the database and in table 1 and table 16. Now we get down into, okay, so if I looked at all of my mortality rates by stat category in table 1, why does that still not match my mortality rate by stat category in table 16? And here is where we apply the model criteria with some new inclusion criteria for table 16. All patients in table 16 have to have a valid age. So in my software, we enter a date of birth and the software calculates the age for me. And I think in other softwares, maybe perhaps you're entering an age, but whatever it is, you have to have a valid age. The sex of your patient has to be male or female. We have an option to put in ambiguous. You want to make sure that you have, to be included, you have to have male or female. And I think in the world of chromosomal analysis and genetic testing, we no longer are likely going long before we know if a patient is genetically male or female. But I know for historic data, perhaps, or people are putting it in because you don't know right at birth when you're putting the case in and you're not going back and updating that. So you want to make sure that your patients have male or female sex entered. Your surgeries have to be in version 3.0 or later. So anything that hasn't been updated to a later version also needs to be fixed. Now, here's my favorite one. Neonates and infants have a separate criterion applied to them, and it's this weight for age Z-score, and it has to be between -7 and 5. And what we know about these weight for age Z-scores is that it gets rid of our outliers. Babies that have severely low weights at time of surgery, and perhaps older patients that have severe high weights. So it gets rid of those. And I would tell you that in my own data, this is where I get caught. This is where my patients get excluded from this table. So let's look at some more data. So I have a patient that underwent, I really don't, but just for fake sake, it was based on an FAQ that was submitted to the box. A patient underwent a banding of a PDA. There was no procedure code for this. So our response from the core group to this data manager was, you're going to have to code this as other procedure cardiac. So with an other procedure cardiac, there is no associated stat score. So what happens to this case? Whether the patient lives or dies, what happens in the analysis for this case? So there will be inclusion in the overall mortality calculation in Table 1. They do show up there. However, this patient, alive or dead, will be excluded from the mortality analysis by stat mortality category because there is no associated stat score for this particular procedure. And they're then excluded from Table 16's analysis as well for the same reason. Again, there's no stat mortality category assigned to this. So this is a table directly from my IQVIA report. I exported it right out of Table 1, where I could see quickly who did not have, or why were cases excluded between the overall operative mortality versus the mortality stratified by stat mortality category. And I could see I had 2 patients in my file. Obviously, I deleted some rows of data to illustrate it here, but I had 2 patients in my entire 4-year file that underwent procedures that did not have affiliated stat mortality category or stat mortality scores associated with them. So they are then excluded from the further analysis. Okay, so now the denominator. I think this is harder to figure out. And again, I've made up data here, but I made this table myself. And I looked at my Table 1 and added up all of the mortalities that are included under my stat mortality stratification. So my number of mortalities was vaguely 31, and my number of eligible operations from Table 1, if I added up the denominator for each of those stat categories, was 1,500. So then I did the same in Table 16, and I went to the very top row of data, and I said, what is my number of mortalities for all patients, so including all age groups? And that was 31. So yay, I have a match there. However, my number of eligible operations is 1,497. So I have a discrepancy of 3 patients that I need to figure out why were they excluded. They were included in Table 1, which means they don't have missing data. It means that they do have a stat score, but why are they now missing from Table 16? So I like to break things down because if you have a denominator of 1,500 cases, I can't one by one go and look at 1,500 cases to see who is and isn't in a table very easily. So I then put side by side all of my mortalities and number eligible from Table 1 to Table 16. And I was able to drill down that I have 2 patients in stat mortality category 2 that were excluded. And I have 1 patient from stat mortality category 3 that was excluded. So what I can see now is I've got this whittled down to about 600 cases that I need to look through rather than the total 1,500. What I did then was I started with stat mortality category 2. I exported the eligible surgeries from Table 1 into Excel. And then I exported the eligible operations from Table 16 into Excel. And then I compared the operation IDs, and I could quickly identify by writing a little code, which may require a further webinar. You can use a VLOOKUP or all kinds of different things, tools in Excel that you can use to identify this. But it took me minutes to identify these 3 patients that were then excluded. So then, next slide. I now have to go back to my software and I have to figure out what is going on with these cases that upon analysis, I had 3 patients that did not hit Table 16. Why were they excluded? So I take you back to remembering the inclusion criteria that are special for Table 16. You have to have an age, you have to have male or female sex, version 3.0 or later, and then this age, weight for age Z-score. So when I looked at all 3, I really do have 3 missing cases. I made up other numbers, but I really do have 3 missing cases. So I went down my rabbit hole to try to figure this out. And all of my cases had appropriate age and sex, male or female, and we're all version 3.0. So now I'm a little stumped. So I know I'm at this age for weight Z-score. And what I realize is when I look at these 3 patients, I have 2 patients where we made a keystroke error with the decimal point. So I have 2 neonates who weigh like 60 pounds. And so it's a valid weight for a patient. It's not a valid weight for a neonate. But so then there wasn't a software catch for this. There wasn't a way to catch my error. So these were excluded appropriately because they look like they are the fattest neonates on earth. And really, it doesn't make sense. But so they were appropriately excluded because they would have a weight for age Z-score of greater than 5. And so I now updated those, and in the next harvest, that will be taken care of. My 3rd patient who was excluded had an incorrect date of birth entered. And so it was entered as this year, so 2020, I'm sorry. And the patient actually was an adult patient. So while their weight was correct at 99 kilos, if you make the patient an infant instead of an adult, again, that weight is atrocious for an infant. So I had 3 cases that were excluded that were all data entry errors. And some of these cases are older, so I do have to give a plug to IQVIA for allowing us to be able to go in and drill down and see why patients were excluded. And so this was great, and I was able to now update that data, and it'll all be rectified with the next harvest and get uploaded. And I will no longer have those 3 patients excluded between tables 1 and table 16. So it was on me, the errors were on me, but they were appropriately excluded by how the table was supposed to work. And I was able to drill down and identify those. So I was incredibly happy to do that. What we will do moving forward is I've already written some queries that I will be able to now look at all of my neonates and infants and their weights. And if I, again, have 100 or 200 pound infant, I should know that that's a problem and make sure I capture that before, or catch that before it goes out the door and before it gets uploaded. So table 7 was another question that I've received this week. How does it fit in compared to table 1 and table 16? So again, it has the usual criteria applied for completeness of data for mortality analysis. And where you get into, it includes an overall mortality rate, and then it's stratified by your stat mortality score. So again, you must have a primary procedure that's associated with a stat mortality score. And the table then just presents your participant mortality rate and your 95% confidence interval. And your comparison group is now the STS aggregate mortality rate. And you have an overall mortality, and then by stat mortality category as well. And then it breaks it down into the 10th, 50th, and 90th percentiles. And then it gives you a min and max rate. So the graphic below then breaks it out by overall mortality, stat mortality category, and it goes through and shows your program compared to some of the comparison STS aggregate rates, and it gives you a nice depiction. So I think this is something nice, like if you have some data to present to your surgical teams or to your surgeons probably know this, but like maybe administration, they're nice graphics that are put together, and you can really see where your program falls because of the red line and the black lines that you can easily see if you are, faring better or worse than STS. Now remember, it is not risk adjusted. And so it doesn't look at all your patient factors and take those into account. It's just stratified by the stat mortality score. And so it's raw data, but still useful and important. So it's just a different way, again, to look at a population. So that's how table 7 differs from table 1 and table 16. So one thing I'd like to point out about table 18 and table 19, there's a calculated median post-op length of stay. And as it was pointed out at AQO, the length of stays are much less now as compared to previous reports. So we really wanted to look in and review the calculations that were used. So what we realized is there's a new calculation that's being applied this time around. So historically, we calculated the post-op length, median post-op length of stay as a median of the means. But now what's being calculated is the true median post-op length of stay. So the point here is, remember this when you're comparing your post-op length of median post-op length of stays to previous analysis reports. And it's probably a point to educate your surgeons and your teams or administration or anybody that is looking at data over time so that they understand that it's not that everybody's length of stay got better, it's that we've applied a new calculation to the median post-op length of stay. All right, I think it's time for Leslie.
Yeah, thanks, Chastity. I was asked just to give a couple updates following AQO. We got some feedback on some of the slides that were presented. So the first one, this is in relation to the discussion around the 2020 stat mortality scores. So there was an update or a revised timeline from the slides that were shared. So the 2021 harvest deadline has not exactly been announced. We know we're looking at mid-December, but because we don't know the actual close date, we don't expect that reports will be released in January of 2022. Currently, the plan is to return to our regular harvest schedule in 2022. So that would mean about a March and September deadline, March for your calendar year and September for your fiscal year reports. But just keep in mind, remember that harvests are continuous. So you can always go in there and submit your data even through, yesterday if your practice allows. just so that we're not getting any further behind. Okay, Leanne, next slide. This is just a snapshot of what I was referring to with the timeline that came out for these 2020 scores. This January 22 received the fall feedback report. That will not be happening in January. Next slide. Okay, the next up is related to the 2020 stat score use. It was mentioned in some of the slides that IQVIA would be giving us a report to show the primary procedure mismatches between the new scoring system and the current scoring system. That report is not developed. They do have the scores, of course, for analysis, but that work has not been done. And of course, as most of us know, vendors do not necessarily have the 2020 stat scores either. Those were published, but it was not a requirement for anyone to actually go in and make updates using those. And therefore, the implementation of the new 2020 stat scores is under discussion. And that really came from a lot of feedback. Thanks, Leanne. Sorry, this is where that was mentioned in the slides. That came following a lot of feedback about what is this going to look like and what happens to our data, and kind of, you know, there's two different pieces there. There's the analytics, and then there's how we're entering codes day to day. So this is in an effort to not put any more burden on data managers. We don't want to cause a bunch of extra work, but we also know that there's a lot of work that needs to be done in developing, testing, and implementing this type of report so that sites know what's happening to their data. Okay, Leanne, next slide. So in summary, 2020 reports are not expected in January. The harvest close for 2021 is expected by the end of the calendar year. 2022 harvest should follow a regular or twice a year schedule. And then exactly when these 2020 stat mortality scores will be used for analysis is under discussion.
Excellent. Thank you so much, Leslie and Chastity. I appreciate your updates. So next we are going to turn things over to our IQVIA team for our IQVIA updates. Joe, the floor is yours.
Thanks, Leanne. Thanks to Chastity and Leslie as well. Good afternoon. I just have a few items to bring up today, starting with a couple items that were released on the weekend of October 9th, both regarding the primary procedure mismatch report, SCS 7126. The primary procedure mismatch report exception rule 1 had been being ignored and was using the general rule, resulting in VSD repairs being displayed as the recommended primary procedure. Again, that has been resolved as of an update on October 9th. And then SCS 7240, we did identify specific situations where the exception rule related to codes 1280 and 1660 was not being properly recognized, and that should be resolved now as well. Next slide. Thank you. So a couple items here. These are planned to be resolved in our next release. We don't have a date to announce for that yet, but they are slated to be fixed in the near future. For the missing variable report, SCS 6892, the MVR is currently flagging data elements as missing, even though the demographics form version is prior to when those variables were added. So we will be adjusting the report logic to correctly take into account the demographics form version so that those are not flagged incorrectly. STS 7282, the anesthesia adverse event update to the calculation. Sorry, so will be an update to the calculation for the missing variable report so that the anesthesia adverse event variable is captured correctly. And then SCS 7271, the COVID-19 variables, temp code and temp date, as well as the hematocrit prior to circulatory arrest or cerebral perfusion variables will be added to the missing variable report calculation as well. Then one last item here in regard to the case eligibility and mortality analysis report, SCS 7380. The report should be displaying the MT30 stat variable as missing when the unknown option is selected. And that's not currently working as it should. And so that will be fixed in the near future as well. And I think that covers it. As usual, if we didn't mention something that you had reported, please rest assured that we are looking into it. You're welcome to contact us to request any updates, and we will be posting to the library and the known issues that are currently being worked on. And I think, Melanie, you did have something to add in regard to
Yeah,
that?
well, actually, you covered it. It was in regards to just by tomorrow, we will have the latest version of the known issues. There are a couple of items that we're reviewing now related to the risk adjusted report. So we are working through reviewing those items and confirming if those are known issues. So the updated list will be in the library and that will be available tomorrow. Thanks, Joe.
Thank you. And I think that covers it for me as well.
Excellent. Thank you, Joe, Mel. I appreciate it. All right, so our final slides, you guys are very familiar with these. As Chastity had indicated earlier, if you have questions regarding your reports, please reach out to IQVIA Tech Support for assistance. Unfortunately, I know in the past I had access to your data and I could assist with some of the questions, but now with data warehousing is at IQVIA, I no longer have access to your data. So again, any report related questions, you should start with IQVIA. And then if IQVIA is unable to answer your question, we'll follow the typical path. It'll go to tier 2. Tier 2 will reach out to DCRI and STS as needed, and we will follow that process and get answers for you and get back to you regarding your questions. But again, reach out to STS Tech Support at IQVIA.com. That would be your first point of contact for report related questions. List of resources. You all are familiar with this list. Again, this is just a list of the resources that are available to you out on the STS website. If you are not able to locate the information that you're searching for, please feel free to contact me directly. My email and phone number is located here. Email is easiest and the best way to get in touch with me. Please know that I am still catching up. I am working through all of my emails post AQO. So if you have emailed me and I have not responded yet, I am working through all of my emails. So thank you very much for your patience. If you have any database operational questions, please reach out to us at stsdb@sts.org. And of course, database operational questions include questions regarding your participation agreement, your list of your contacts associated with your site. If you have any questions regarding to invoicing, or you have questions, issues with platform access, again, reach out to us at stsdb@sts.org. Please mark your calendars accordingly. Our list of upcoming CHSD webinars, our next user group call is scheduled for November the 2nd at 12 p.m. Central. Our next monthly webinar is scheduled November 18th at 12 p.m. Central. And again, our December user group call is scheduled for December the 7th at 12 p.m. Central. If you have any ideas that you would like covered for educational on our next monthly webinar, please feel free to email any ideas to either Chastity and myself. And again, if you just email me directly, I'll share those with Chastity so we can provide educational information that is beneficial and timely for you guys. So again, we welcome any and all ideas for our monthly didactic webinars. All right, that is all that I have from the STS perspective and IQVIA side. So we've got about 20 minutes left. So we will turn things over to you guys for our Q&A. I see questions are already coming in. So let's go ahead and start tackling these. Again, let's go ahead and take our first question from Jennifer. Since the last harvest was 7/1/2016 through 6/30/2020, and the next is 7/1/2017 through 6/30/2021, we'll be able to filter our reports to show a time frame of 1/1/2017 through 12/31/2020. So it depends on the reporting period, because you have to remember the risk adjusted data is a snapshot. So it's so that data comes directly back from DCRI, and the current reporting period the task force is considering is following the same as we did for the 2020 harvest, using the fall reporting period. So it would either be based on the spring or the fall reporting period. And again, we're going based off of our 2020 harvest, and the fall. This 2021 report would be based on 7/1/2017 through 6/30/2021. So if that data set comes back from DCRI, you would not be able to filter based on 1/1/17 through 12/31/2020. Again, because it's a snapshot of the data in that time. And again, Becky, is the same along the same lines. So right now the task force is looking at the reporting period following the fall reporting period, just as we did in the 2020 harvest. Chastity, how did you drill down into that exact patient without scrolling down a long list to look for that op ID?
So I wrote some Excel code, which again, maybe I can put some slides together. Since I know you put out a nice email today, Diane, with how you wrote some Excel code to make something happen. And so perhaps I can put something out there and send it to people or include it on the next webinar. But I wrote some Excel code to do some matching. You could also do a VLOOKUP. And so we can get that out there so you guys can do that. It's kind of high level and I understand that. And so more than an explanation off the fly that I could give, but we'll get it together for you.
Great, thanks, Chastity. All right, from Becky, in reviewing prior harvest overview reports, I don't remember ever knowing there was a Z-score weight exclusion for table 16 cases. Where can we find that information so we can show our surgeons quality team? Sure, here, let me actually, well, I saw this question come in, so I pulled over. This is the fall 2019 report overview. And in the interpretation guide on page 50, starting on page 54 to 55, this is a list of the model inclusion criteria. And if you note here under operation level inclusion criteria, this last bullet here for neonates and infants weight for age Z-score between -7.0 and 5.0. So that information can be found in the fall 2019 overview, and it is also listed, I think, in the current analysis overview. So I hope that helps, Becky. Let's see here. From Kelly, are there complications that should be captured at hospitalization and prior to the surgery? In the training manual, some of the complications state code only if newly diagnosed at this hospitalization. Specifically, the thrombus complication categories. This is confusing due to the overarching definition of a complication of intraoperative, intraprocedural complications, and postoperative, post-procedural.
I can take this one. So Kelly, when it says code only if newly diagnosed at this hospitalization, it's still referring to the intra-op or post-op, post-procedural time period. So it's not pre-op. So anything that would occur pre-op would be a preoperative factor if it's in that list. And so we're not collecting complications prior to the surgery during the hospitalization. We're still collecting in that during surgery or post-surgery time frame. It just means that it's only if it's newly diagnosed. So like if you go into the OR and you have a known thrombosis and then you come out of the OR and you have the same thrombosis, it's not a complication or an event that occurred post-OR. We knew about it ahead of time. There are others that even though you have a seizure disorder, post-op, you have a seizure. That's an event that occurred post-op. So it doesn't mean it doesn't have to be new in the definition post-op. It's just in the post-op arena, you sustained a seizure. You had the event of a seizure. Does that help? And if that's confusing, we can play with that wording. I hear what you're saying.
Yeah. Thank you. Thanks, Chastity. All right. So our next question from Christy asking about the post-op length of stay calculation. So I did put the slide back up for you, Christy, regarding the median post-op length of stay. So if you have any other questions, just please feel free to reach out. I'll leave this slide up here for you. And these slides will also, once the webinar is over, I will PDF the slide deck, and the recording will go over to our marketing team, and it will be posted on the STS website, so you can go back and download the slide deck. The slide deck will be available within 1 to 2 business days from marketing, so it will be available out on the STS website on our webinars page. All right, for Maggie. So should we be asking our vendors to update 341 with the 2020 stat scores or wait until further decisions are made by STS about when they will be utilized for analysis? So Maggie, I would hold on and please wait for formal communication from STS. STS will get the updated stat scores. We need to also post those out on our STS website. The Appendix C has not been updated as of yet. So again, I would encourage you to please wait for formal communication from STS. When will vendors have access to the upgraded DCF specs, the new procedures, and the new 2020 stat mortality codes? My vendor says he cannot add any new procedures now and sees no way for it to be ready by July. if the specs aren't released before January. So the new DCF, okay, so the DCF 6.22 upgrade goes live July 1, 2022. The specs will go to the vendors in January. Vendors will have 6 months to get that information updated, as they always have in the past. So, we have so the specs will go to the vendors in July, in January of 2022. So again, we've always given them 6 months to get that updated. So if you'd like to discuss that, Rachel, offline, please feel free to email me. And the new 2020 mortality codes, again, more information will be coming about regarding the 2020 updates. So more information will be coming from STS about the formal implementation of those 2020 stat codes. From Peter, in the old STS report, we used to have a list of the individual procedure mortalities. Is the expectation to use the new CHSD participant dashboard report for drill down to that level now? Melanie, I don't know if someone from your team wanted to address that one.
This is Jeff Jacobs. Ram and I have discussed this, and this is one of the tables that was in the old report that broke down outcomes of an individual program and of national aggregate data for every single procedure in the database. And that particular table was not part of the most recent feedback report that just was released. But I know that Ram is discussing the possibility of resuscitating that table and adding it back at a future feedback report. So that one would then have the ability to look at, again, the individual outcomes of any operation at a given program compared to national aggregate data. So we know that that table was not part of this feedback report. It may very well be part of a future feedback report. I hope that helps.
Thank you. Chastity, this is for you. Could you please explain more about Table 6 Norwood? I don't see it in our report.
I don't have a table 6 Norwood. Yeah. Are we speaking to the lesion specific reports, table 28 for HLHS, or?
Yeah, I'm not sure. If you could clarify, that would be helpful.
Yeah, provide a clarification and then I'm happy to speak to it.
Yeah. And from Jen, from my follow-up, so we'll be missing one report. Again, the task force, the current decision is to follow the fall 2020 reporting period and use for the fall 2021 harvest since we're only having the one harvest. Again, more information I can provide further clarification on that. We do have a task force call next week. So again, STS will be sharing more information, formal communication next week regarding the harvest close date, implementation of stat score rollout. So again, a formal communication will be coming from STS next week. So sorry, Jen, if you could just stay tuned. I promise more information will be coming once final decisions are made. But based on the 2020 harvest, and since we only have one harvest then, the task force is considering using the same reporting period as we did in 2020. And Diane was clarifying, she meant in IQVIA. Will there be a site-wise comparison chart like in the old report? And I think they were talking about the volume tables. But again, the goal of the congenital database is not to compare your institution to other institutions. The goal of the purpose of this database is to compare your site to the STS aggregate. All right. Thanks, Chastity, from Kelly. Thanks, Chastity. I believe the wording should be revised for the thrombosis complications to prevent confusion.
Got it. Okay, taken.
All right. And from Diane, how do I drill down into a patient in IQVIA to see if they match our data?
Like looking at the case form, so you can see what was submitted and then versus what you have locally.
Yeah, I don't know. Yeah, Diane, if you could clarify, or if you want to raise your hand to discuss, that might be a little bit easier, and I can unmute you. That way, you don't have to go back and forth through email if you're able, or through the Q&A. From Dawn, okay. And again, if you can please submit if you can submit your questions via the Q&A and not the chat, please. I'm sorry, I'm just trying to work between the two, and it's easier for me to have all the questions in the Q&A. But again, please just submit your questions via the Q&A. All right. I think Diane, Ruthie has her hand raised. If you could
Hello,
unmute.
can you hear me?
Ruthie.
Hi,
Yes.
everybody. I'm not sure if this is what Diane was asking, but I kind of had a similar question. Was that how can we see what DCRI picked as our primary procedure, like to make sure, because we're not able to see that when we drill down. So if there's a mismatch, because if we're noticing, oh, you know, for me, I had it down in my local data as a stat 4, but or a stat 2, and now I'm getting a different stat score. I'm getting a stat 1. I'm like, what did they pick? Like, I want to know exactly which so what was the primary procedure that was picked for me and during analysis.
And Ruthie, this was different than your primary procedure mismatch report in IQVIA?
Yeah.
Okay. Was it one of those?
And it could have been, and it
Yeah.
could have been a new one, but I'm just like, maybe just a way that like we could get like what was the actual, like after analysis, like what was what's the final like
What was
primary
selected.
diagnosis and primary procedure. Like that would be a nice enhancement.
Yeah, that's something that we could take back, Ruthie.
Yes.
Thank
Yes.
you. Yep,
Good
thank
point.
you. All right, okay, thank you. And Diane, I see, okay. So Rachel is clarifying that the US News references table 6 stats, but we don't see a table 6 anymore on our report.
There isn't a table 6 in this report.
Right, I can touch that. The U.S. News team is aware of that fact that table 6 is not part of this report, and U.S. News will be able to obtain that data from the Norwood specific table that's at the end of the report. So in the next U.S. News survey, they'll change the source of information from table 6 to the table that talks specifically about hypoplastic left heart syndrome later on in the report. I hope that answers the question.
Yes,
So that would be table 28.
Right. Yeah, I just didn't know the number off the top of my head,
Yep.
but table 28. So that the new report will be cognizant of the fact that the table 6 is no longer there, and we'll obtain that information from table 28, as Chastity pointed out.
thank you, Dr. Jacobs.
You bet.
All right,
Oh, by the way, you guys really did a great job with these presentations today. I'm sitting here with Connie watching all of this, and really good work. Congratulations.
Thank you, guys. Yeah, Chastity and Leslie and IQVIA, they did an amazing job. So let's see here from Dawn. How can we know which procedure codes are represented in the lesion specific tables? So that information is available. There's 2 locations. It's available in the analysis overview, as well as the calculation spreadsheet that IQVIA has available within the library. So hold on, let me pull up. Let me go to the website. Hold on just a moment. So I'm going to pull over my site. So if you go to the IQVIA library, we have the CHSD analysis overview here. And go to the bookmarks. We have let's see here. We have the criteria for, here we go. Here is the criteria for the required primary diagnosis and procedure list for inclusion in the lesion specific reporting. So this is on page analysis overview. It starts on page 19 Dawn, of the analysis overview. And then also within the library, this is the CHSD risk adjusted calculation spreadsheet that is provided by IQVIA. And this, if you have not downloaded this, I encourage you to download the calculation spreadsheet. It outlines all of the calculations currently in the report. And Mel did cover this in our last webinar. She gave a nice overview of what this document is and how it's used. So again, I do encourage you to download this calculation spreadsheet, and it goes through each one of the tables, includes all of the criteria for the calculations for each table. And this includes the lesion specific sections. So we have the ASD, we have table 20, each table in the lesion specific section is outlined here. We have the primary diagnosis, primary procedures, and then the calculations for each variable in the table. Okay, let me see here. I hope that's helpful, Dawn. Let's see, can a report be made to validate inclusion in table 16 prior to submission? And again, as Ruthie had stated, requested, this would be an enhancement, and we can add this to the list and discuss with IQVIA and DCRI. Diane was just clarifying that what she's looking for. And Diane, if you would like to submit that to IQVIA, we can look into that further. So if you could submit that to IQVIA, if you've not already done so, we could look into that further. Let's see, is the plan still to utilize the 35 new combination procedure codes in the upcoming harvest, although it sounds like IQVIA isn't going to be able to provide us a report specific to the mismatches that will occur when a procedure falls into one of the new combination codes and will be different from the procedure selected by the data manager. Again, Maggie, this is currently under discussion with between STS and task force and IQVIA. So again, we are looking, it's currently under discussion. A formal communication will come out from STS in the very near future. So again, please stay tuned.
Those, Leanne, just real quick, the combination procedure codes are different than the update to the scores, and that is for 622. So that is not something that'll be in the next.
That's right. Correct. Thank you for that clarification, Leslie.
Yep.
Thanks for keeping me straight. But yeah, those are the 35 new combination codes. I think those are the 5,000 series codes that were in the paper. But again, yes, those are coming out with 6.22.
Yeah, exactly. You're 100% correct. Those are the codes that are 5,000 codes in the manuscript, and they are now on the new data collection form with the same 5,000 numbers. And when the new upgrade is operationalized, they will be part of the new upgrade. You're 100% right.
Thank you. All right, Chastity, this is a question for you all. Should the complications be entered only on the index operations, or does it have to be a high stat category? Is it okay to not enter complications on the procedure performed after the index operation?
Dita, I know we have a call tomorrow. Let's take this there because I think that this is a big question, and I want to give you a really good response. And I think that there's a previous webinar where we talked about this too, and so I can pull that up. So let's bring that up tomorrow if that works for you.
Perfect. Thank you. Yes, we do have a one-on-one with you tomorrow. All right. What STS communication or updates have been provided to the surgeons in regards to the new report, modifications, upcoming changes, etc.? Do the surgeons get any updates? Do the surgeons get updates on any of this directly from their surgeon leadership? So in regards to formal communication, so again, we are discussing the upcoming 2021 analysis. Formal communication will go out to the data managers and STS surgeon representatives. So again, more information about that is coming, Heidi. Donna, I don't know if you wanted to touch on any of on Heidi's question, but we will have formal communication regarding the reports forthcoming, and it will go to the surgeon leaders as well.
Yes, the surgeons are included, the task force, as well as newsletters and emails and blasts to keep people updated.
Okay, so Becky, looking at the Excel calculation, it seems that only index cases are included if a patient has PA bands paced as the index procedure, will the Norwood procedure still show up? I don't know. Melanie, do you want to take that?
About table 28.
Table 28, yeah.
And so if your index case is PA bands, then that's all that is going to show up in table 28. So if you're referring for US News, that will you have less procedures included for US News? Yes, but all of us will, since it'll only be the index operations.
Perfect. Thank you, Chastity. Okay. For Maggie, I must have misunderstood at AQOs. I thought I heard the new combination codes would be utilized in analysis of the spring. No, not waiting for the upgrade of 622. No, the new combination codes, they have to be implemented with 6.22. Those new combination codes don't exist in the 341 data version, so they can't be applied to that data. So those new combination codes can only be applied in version 6.22. So again, all of those 5,000 series new combo codes cannot be implemented until the release of data version 6.22. Heidi, thank you for the communication to them. To be honest, it's a lot to track and convey and it's somewhat confusing. I agree with you 110%, Heidi. It is a lot to track and it's a lot of information and it is very confusing. So yes, we'll have formal communication going out to the data managers and our surgeons and surgeon leaders. So I agree with you 110%. Excuse me. So it's like our last question from Angie. Is it possible to provide a video for surgeons on the new platform, recent report, and how to interpret recent feedback reports? So I think this is a very good idea. Melanie, do we have a video of, I think we have a walkthrough with the surgeons for the new report. Did that happen or do we have that or did I imagine that?
The walkthrough that we did in the webinar?
Yes,
We didn't do a yeah, we did a video. I mean, we did the recording of the last webinar where I did the walkthrough.
Yeah.
So I believe that's already posted and available in the last actual session, which would have been like October the 5th. So that last webinar, we did do that walkthrough.
Okay. Yeah, and Angie, if you have more questions or looking for additional information, please feel free to email me. All right, so I'm at time. I know several of us have to have other calls, other webinars that we have to get to, so I do apologize. Amy, I see your question and I can follow up with you directly. But yes, the new combo codes are, those new combo codes are being implemented in version 6.22. Those 5,000 series codes, again, are new to version 6.22 and are being implemented with the release of version 6.22. So I hope today's webinar helped to clear up a lot of post-AQO confusion, additional clarifications just to help clear up confusion. So again, if you all have any questions, please feel free to reach out to me directly. Again, formal communication will be coming from STS, will be forthcoming here soon. We have a task force call next week. Again, formal communication will be coming regarding the 2021 analysis, implementation of the new stat scores. So again, please wait for that formal communication from STS. And again, please follow up with me if you have questions. I just want to thank everyone today. Thank you to Chastity, Leslie, IQVIA team. Thank you everyone for participating and for providing today's webinar. Thank you guys, everyone. I hope you guys have a great day. And again, let me know if you have any questions. Thanks, team. I appreciate it.
Really great job, Chastity and team. These presentations were outstanding.
Yep. Thank you, guys.
Good. Thank you. Thank you, Leanne. I know you do the bulk of the work here.
Couldn't do it without you all and our data managers. So thanks, everyone. Have a great day.